Join us this evening as we host one of our viewers' favorite shows, Ask Anything. Tonight's show focuses on all medical topics affecting those in our viewing audience. Ask Anything tonight on Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. I'm Dr. Kelly Evans-Hullinger, your volunteer Prairie Doc for this evening's program. Tonight we are hosting one of our viewers' favorite shows, Ask Anything, where you can call in with any medical question about any topic. In the studio this evening are Dr. Alan Sazama from Avera McKennan Emergency and Dr. Carl Rasmussen from Sanford 49th and Oxbow Family Medicine. Thank you both for being here with us tonight. Appreciate it. Alan, tell us a little bit about yourself and emergency medicine. I hope our viewers might not encounter you a lot, but what do you like about emergency medicine?
Yeah, so my name is Alan Sazama. I am a USD graduate, graduated in 2014. Went up to do my residency training for 3 years up in St. Paul, Minnesota. Once I got back, done with that, I came back home to South Dakota and started working at Avera Health. And been there about 9 years now. What drew me to emergency medicine, I like variety, I like the fast pace, I like being able to help people that have an acute need. And I liked a little bit of everything in medical school, so that's where being in the ER where I get to do everything has been nice.
Yeah, you never know, right?
Never know.
Okay. Carl, how about you? Tell us a little bit about your background and what you do in family medicine.
Yeah, I'm from South Dakota originally, and went to USD for medical school, went out west to Oregon for the rest of my training, practiced in a couple different locations, and then moved back to South Dakota about 3 years ago, and have been with Sanford since. I do a mix of regular primary care, family medicine, and then also sports medicine, non-operative orthopedic work. And yeah, kind of like Alan was saying, I like the variety. And so even though we kind of see different ends of the spectrum in terms of level of acuity, I like the variety in my work. And get to work with patients of all ages and work with some issues that are more acute and some issues that are more chronic. And so, yeah, it's a good mix.
Yeah, thanks for being here, guys. Before we get into tonight's discussion, I'd like to take a moment to thank our viewers. As a volunteer Prairie Doc, your support each week matters. Every dollar you give helps us produce science-based content that empowers individuals to make informed health decisions. Now let's turn our focus to you, our audience. We invite you to submit your questions for tonight's conversation on any medical topic. There are 3 ways to reach us. Call us at 1-888-376-6225, send an email to ask@prairiedoc.org, or engage with us on our Prairie Doc Facebook page. We will do our best to address as many of your questions as time allows. If we can't get to yours, we sincerely apologize. All of your questions are anonymous and no information will be saved. However, if you would like to leave your name, email, or phone number, you'll be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie. It's not a requirement to submit a question. We'll announce the winner at the end of the program. So we already have a bunch of questions. Let's just get to them. We'll see kind of where it takes us. I'm going to start with one that's fairly topical, been in the news quite a bit. We had a question on Facebook about there have been some reported cases in our state of measles. So let's talk about measles, I guess. In those communities where we might have cases, do all unvaccinated kids with an exposure have to stay home, or just the ones that might have been exposed? How many days do they have to stay home, and why is that? You want to start, Carl?
Yeah, I mean, it's not something, fortunately, that I've had to deal with directly, but I know there have been some cases, and it's on people's minds and on our radars as healthcare providers. I would say if you have a concern, about potential exposure, potential symptoms, for sure reaching out to your medical provider. And, maybe in that case also like calling ahead and not necessarily just showing up, see what the protocols are in those situations, because it is potentially a very infectious, transmittable disease, a viral disease, one that there are good vaccines for that start in childhood. And so, again, kind of the biggest thing is prevention and trying to make sure your kids and yourself are up to date with the measles vaccine.
Yeah. Have you seen anything in the ER about this, or what are we hearing about?
Yeah, we've seen, so as you can imagine, with measles, a lot of the early symptoms are upper respiratory viral illness, which I see, it feels like a million of every single shift I work, especially this time of year. And, what I tell people is, just what Carl was saying, if you have a concern for this, absolutely come into a healthcare provider, whether it's your primary care physician, whether it's coming to the acute care, the ER. We've seen cases in the emergency department that we're testing for measles just because there's enough concerning factors. A lot of those are send-outs to the state, so you don't necessarily get the right-away answer. But to answer the question too, prevention is the key here. There's not really a treatment for measles, right? So if you're unvaccinated, if there's somebody that's measles, you want to quarantine and watch yourself, just because you are prone to get that more than somebody who is vaccinated. So that's where when we talk about vaccines, that's a big part of it, is that we're just trying to prevent some of these diseases that can be fatal. Not all measles is fatal. It's important to say that too, but it can be. So that's where prevention becomes a big thing.
Yeah. And if you're vaccinated, we expect that you're immune. Vaccines are really effective. I took a question today from one of my older patients. I didn't get vaccinated, so what do I do? Well, the guidance is if you're born before 1957, then we assume everybody got measles, and so you should be protected. And I've seen the communication about this outbreak, and the CDC guidance is if you have an unvaccinated child who did have an exposure, it's 21 days of staying isolated, because that's just how contagious this disease is. So unfortunate situation, but I think good to be informed. Great. We had a viewer from Platt ask, how rare is polymyalgia rheumatica, and are there correlations with blindness? I love this question, such a smart question. Carl, you want to start about this?
I wouldn't say it's common. It's also not super rare. So, polymyalgia rheumatica is an inflammatory condition affecting multiple muscle groups. And so it's something that's on our radar, especially if somebody has kind of what we call symmetric symptoms of kind of muscle pain, often more in the shoulder region. And if it's just kind of this onset that, kind of comes on out of the blue, no injury, it's something that's on our radar. There are tests we can run, specific inflammatory lab tests that can kind of point us in the right direction. And it's definitely something that's treatable. It can take a kind of prolonged course of being on steroids to treat it, but it is something that we usually are able to treat. Kelly, you might have to remind me the blindness piece of it, but if I remember right, I think that there's something along the temporal artery that we worry about.
Yeah. You got it. So it's an association. It's not like, the polymyalgia rheumatica doesn't cause blindness, but a disease that can go along with it can cause blindness. So smart question. Yeah. Alan, here's one for you. This is an email question. I had a cold a few weeks ago and still had a cough for a bit. Last week I got a sharp pain when I took a deep breath, and then I'd cough and it'd go away. Doctor said it's probably pleurisy. What is that exactly? I imagine you see some cases like this not infrequently come into the emergency room because chest pain is scary.
Chest pain is scary.
Yeah.
It can be a lot of different things. I think of pleurisy, how I describe it to patients, it's, you've had something happen to your lung. So it's, in this case, an infection, probably a viral infection. Your lung is inflamed. And when you think about, if, you're working in sports medicine and sprained my ankle. It's sore. It hurts to move it, and we don't want. And for an ankle sprain, we have you rest, right? Like get off of it. I don't want you to rest your lungs.
Right.
You got to use them 20 times a minute, right? Hopefully. So that inflammation can go on for a while. So I tell patients most of the time pleurisy itself is not harmful. Some of the things that can cause that sort of pain, however, can be blood clots in your lung, or something that pulmonary embolism is something that I work with in my field a lot. But part of our training in the emergency department is trying to figure out the signs and symptoms to rule out what's pleurisy, which is an annoyance, uncomfortable, versus something that can be really life-threatening.
Yeah. Great. We had an email question. I hear a lot about raw milk in the news. Is it safe to drink, and why is this in the news? I guess I don't know if we're going to know why it's in the news, but is raw milk safe to drink? What would you counsel someone who came in and asked you that?
I'd be careful with it. There's bacterial infections that somebody can obtain by drinking raw milk. That's why we have a method of pasteurization for milk and dairy products. So that's why that method exists, is to try to minimize risk for bacterial infection. And so that's the main thing I would be concerned with.
Yeah, for sure. I always say, probably the reason we live as long as we do, there's a couple things, right? Vaccinations and sterile water and food, and that's probably one example of one of the dangers you can take. But
the example I think of too with that, I could certainly, when I go drive back to Sioux Falls tonight, drive 100 miles an hour on the interstate, and I probably would be okay most of the time. But there's going to be a time where if I wasn't okay, I'm really not going to be okay. That's probably the same thing with something like raw milk.
Right.
You could drink a glass, every day for a week and probably be okay. But if that one time you drink that raw milk that's got listeria bacteria in it, you're really not going to be okay.
Yeah.
So is it worth taking that chance to drive 100 miles an hour or to drink raw milk? I mean, that's probably up for people to decide, but I tend to think no.
Yeah. Okay, email question. My teenage son has been complaining about his forearm hurting when he puts pressure on it. He hasn't had any falls, it's not swollen or red. Should we just give him Advil and ice, or should we take him in? What would you say?
I think it would depend on duration of symptoms.
Okay.
It's been, a few days, a week, probably okay to watch it a little bit longer.
Sure.
If it's been dragging on for a couple weeks, few weeks, then I'd definitely bring him in, get it checked out. And then we want to try to figure out, hey, are we sure there wasn't any sort of injury or something that didn't entirely go unnoticed? It might be worthwhile, regardless, depending on the duration, to shoot an X-ray, get some basic imaging of it. I would say kind of duration of it being kind of the main decision point as to when to bring him in, and if it's longer than a couple weeks, I'd probably bring him in.
Great. Let's see. Facebook question. I have a mole on my side. It has always been big, but lately it itches and looks like it wants to peel. Should I go in for it or just keep watching? It has not changed in size or color. I'm going to give you that one again, Carl.
Yeah, so it sounds like, without seeing the skin spot, it could be something like a seborrheic keratosis that would fit with the description. Those are benign. Those can, kind of develop fairly quickly. But any skin lesion, if you're concerned about it, if you're worried that, hey, this has changed, it's looking different, the borders have changed, it's gotten darker, something like that, it's never a bad idea to go in and get it checked out. It's better to have us quickly look at it and say, yeah, you're fine, than for it to be something that we should have checked out earlier.
Yeah, great. Let's see, email question. My father-in-law has hydrocephalus and had a shunt put in. It helped immediately, but it's been a year and he's back to having the same symptoms that he had before. He's had it drained twice. Is this something that will always occur, or is there something more that could be done? He's in his early 70s. So I guess we might be missing some information, but maybe you might see people coming in the ER with this history and maybe they're having headaches or something.
Sure.
What would you answer to this, Alan?
I think I have seen shunts malfunction. I have seen then quit working for whatever reason. My best advice, I think, for that person would be probably the neurosurgeon who put it in would be to go back and say, hey, my symptoms are back. They're not like it was. In general, things that were good that got better and then all of a sudden got worse again over the course of a year. I mean, to me, that's worth another discussion to be like, is everything still working? Because if it's not working, the shunt's malfunctioning, well, there's no reason to suffer with symptoms if it's an equipment problem. So I think for that individual, I'd highly recommend just going in and talking to their physician and figuring out if there's something not working right.
Yeah, and I think that phone call to that neurosurgery clinic, they're happy to see you back and check things out for you. Okay, email question. This is a woman in her 50s. I've had hip pain that comes and goes for years. It doesn't hurt when walking or running, but just in the morning. And typically when I stretch a certain way. What might this be, and what ought I do for this type of pain?
Yeah, probably one that if it hasn't been evaluated would be good to be seen, to get a set of basic x-rays of the hip, be able to compare it to the other hip. We're always trying to sort out, is this muscular pain around the joint or is this coming from the joint? That kind of dictates how we're going to manage that. I would encourage going in and getting a set of x-rays because that's going to be able to give us actually quite a bit of information and can point us in the right direction. So yeah, it could be something as simple as some muscular pain, some tendonitis or bursitis, pretty common in the hip region, and is something that we can treat fairly easily with physical therapy and anti-inflammatories. Or if on x-ray we see that there are some arthritis type changes in the joint, it's good to know about that sooner rather than later because we can kind of address potentially how that's going to progress going forward. Yeah, great.
We had a caller, Alan, ask about having pain in the stomach and testicles that started at the same time. It's acute pain, but it comes and goes. Are these things connected, or what things would you be worried about with that complaint?
First thing I think of when I hear that is possible kidney stone. It's probably the most common thing I see that causes pain in the abdomen and testicles, and it's colicky type pain. As the stone moves down the ureter or the tube between the kidney and the bladder, it's made of muscle, and as that rock basically rolls down, it roughs up the tissue, which causes it to spasm, which is what causes your pain to really come on intensely and then get better. So that'd probably be the first thing I'd think of. And there are other things to think of too, of course. There could be a testicular issue, testicular torsion where the testicle torses, and then a host of, it could be a inguinal hernia too. So there's lots of different things, but when I hear those two things that are kind of coming and going, it makes me think kidney stone.
Yeah, interesting. Definitely worth getting checked out regardless. Great. Let's see. We had another email question. My grandmother and my mom both have what looks like a hump on their back when standing, and it wasn't always that way. Is that genetic? How do I prevent myself from getting that? Carl, what do you think?
One thing we think of is over time bone density and how that affects our posture, and that can give an appearance of kind of that more pronounced curvature at the top of the spine. Depending on what the family history is there, if there's history of osteoporosis or low bone density, that's probably something to bear in mind, and that's something that we can test for in a clinical setting.
Great. Well, we have encouraging information in the fight against syphilis, with cases across all stages down by over 40%. As of July 2025, there has been a decrease in syphilis cases in South Dakota since its peak in 2022. Casey Redden-Benz from the State Department of Health gave us more information.
So for the early cases, we have that 51.5% decrease. And for all stages of syphilis, it's a 38.9% decrease.
Redden-Benz says the South Dakota Department of Health has received syphilis reports across all age groups, the highest number of cases occurring among those ages 25 to 39.
We put out paid promotional advertisements on Facebook, Instagram, Snapchat, and Tinder. So really the message just pops up for this age group that, while you're swiping through or clicking through, it'll come up and say, hey, syphilis is in South Dakota. Make sure that you're protecting yourself. And then it directs them directly to our sexually transmitted infection webpage on Department of Health.
The South Dakota Department of Health also has partnerships with federal, state, local, and tribal entities.
I want to say a huge part of this work is also because of our disease intervention specialists. So they're the ones that are working really hard to mitigate syphilis and really in the community. So they're highly trained and they're using investigation skills to connect with individuals that have tested positive or that are contacts to those individuals. And they're reaching out to them by phones of like telephone, but also going to on home visits, connecting with healthcare providers, going to the jails, meeting people where they're at, and then making sure that they're connected with care and gathering information to make sure that we're stopping the spread of syphilis. And when we look at sexual health, a lot of times people don't think of that as whole body health, but we really need to.
The question, I was like, internal med doc in on this one.
I feel like sexually transmitted infections, like we think about a lot. The public, it's like a scary thing to talk about. What advice would you give anyone about asking about sexually transmitted infections or getting screened, Carl?
Yeah, I mean, you're right. It's, unfortunately, it's still kind of taboo, and I think maybe for the patient, knowing like as healthcare providers, like, we don't care, and we want you to tell us, whatever you're concerned about, whatever's on your mind, whatever risk factor you think you might have. So I think being aware that we test for STIs, STDs a lot, so it's not uncommon and we're happy to do it. So if there's any kind of symptoms of concern along those lines, like just going and get tested, go see your provider. We're happy to talk about it.
Right. Yeah, we're happy to test you. What can people expect if they come in for STI testing? It's really not that scary, right? It's like probably urine and blood in most cases.
Yep.
Yeah, unless you need an exam, and we have good treatments for most of these things. So all the reason to get tested and screened. Okay, let's get back to some questions. We had a caller, John, who was recently diagnosed with a basal cell carcinoma on his scalp. Just wondering a little bit about like what this is, how you treat it, or any more information about that diagnosis.
Basal cell carcinoma is not too uncommon when it comes to skin cancers, more in sun-exposed areas, so scalp would be a common area for it. Fortunately not as quite as worrisome of a diagnosis as a melanoma, but still something that we'd want to address right away. And so dermatologists have great treatment options for that. So we would get you plugged in with one of them right away.
Yeah, usually excision, rarely require, and I always tell people the same thing, like these don't usually spread or anything, but a lot of them, if they're on your scalp, your face, the bigger they get, the harder they are to take off. So good to get it treated. All right, let's see. We have a caller asking, I struggle with bowel movements. Constipation, presumably. Is it okay to take Miralax on a daily basis? Do you ever see constipation in the emergency room?
We certainly do, yeah. We see fecal impactions, we see constipation. I oftentimes, and I don't know if this is the right thing to say to two primary docs, but what I often tell patients is if you're not having stools, actually, like you're constipated to the point you're coming to the ER, take more than they prescribe. Like I tell them to do like 3 times a day until you start to have more regular bowel movements. You'll want to back off. Too much can be a different set of problems, right? But I tell people, to take it daily if they're having a hard time, for sure.
Yeah. And even kids, do we use
Miralax? And I wouldn't disagree with Alan. I mean, I think, the ill effects of not treating it are going to be worse. So, if you need to use Miralax on a daily basis, that's okay. But as Alan said, if you can get to a point where things are regular, see if you can back off of that. Kids we use Miralax in as well.
Yeah,
Yep.
really safe.
Yep.
I have older patients who a lot of them use Miralax every day, and I say, maybe you need the full cap a day, maybe it's every other day, but figure out what sort of keeps you moving. So, good question. Let's see, we had a caller from Oklahoma. About a year ago, this person had pain in the foot, primarily on the outer foot going up to the ankle. Their PCP couldn't figure it out. They say tested for gout, but came back negative and it went away. But now it's returned. So they're wondering what could cause pain kind of in that location, I guess. What things do you think of?
Yeah, there could be a number of options. One thing that comes to mind right away is you have tendons called your peroneal tendons that run on the outside part of the foot. And so that foot pain that you feel on kind of the lateral or outside part of the foot, wrapping up to the ankle, that's kind of the path of those tendons. It's a pretty common area to get tendinitis. So that could definitely fit with this kind of pain that they had, went away, and now it's back. So, treatment for that could be anything from temporarily immobilizing in a boot if it's bad enough. Physical therapy could be a great option for this. Anti-inflammatories as well.
Yeah, great. Let's see, we had a caller from Rapid City. This person has seizures. Curious what triggers seizures, what happens, what causes a seizures, and why is there a loss of memory? You want to talk a little bit about seizures? Probably
Sure.
a pretty common presentation for you, huh?
Absolutely, yeah. So when I think of seizures, I think how I describe it to patients is we all have electrical activity in our brain. That's how our nerves communicate with each other. And a seizure is when that electrical activity is out of control. It's gone, turned up to 12 on a scale to 10. And what happens afterwards, and I think of it this way, a lot of younger people don't know this anymore, but when your computer used to get gummed up, you have to do Control-Alt-Delete to kind of reboot things. Your brain does the same thing after a seizure. So we have what's called a post-ictal period, where if you've ever seen someone have a seizure, afterwards they're really confused, have no idea what's going on, where they're at. I think of it as the brain kind of resetting. And as far as the question of what can cause a seizure, there are just seizure disorders, epilepsy, that a patient can just start to have. But there are certain things that can lower a patient's seizure threshold, certain drugs, cocaine, methamphetamine, infection, different medicines that you take for antidepressant, or all sorts of different medicines can lower your seizure threshold. But in general, sometimes it's just that you have a seizure disorder. But those are the things I think of with seizures.
Yeah, and probably most people think of that generalized tonic-clonic, full-body shaking seizure, but not all seizures are like that. How else do you see them present?
Yeah, good question.
Because sometimes they're tricky, actually.
Yeah, you can have focal seizures, which I've seen something as subtle as someone just kind of shaking their hand. Mm-hmm. I've seen what's called absence seizures, where patients are just staring off into nothing. There's lots of things that can cause people to do that in the emergency department, right, where they just kind of stare off. So that's something to have definitely on your differential, but would be an absence seizure.
Yeah, great. Let's see, we had a caller from Ipswich, 87-year-old, and in the last year, their eyesight is getting worse due to macular degeneration. She asks, will they lose all their eyesight or possibly go blind?
Yeah, I'm not an ophthalmologist. Mm-hmm. It's, unfortunately a fairly common condition as people age. Mm-hmm. There are treatments that can be used to help kind of slow the progression of it, and so I guess I would make sure that if they're not established with an ophthalmologist, that would be for sure a first step. Mm-hmm. So yeah, seeing an ophthalmologist, seeing what they can do to slow the progression. It's not something that unfortunately can be reversed, but yeah.
Yeah, unfortunately, it is a common cause of blindness, so it's possible. Let's see, we have a caller from Rapid City, 85-year-old with terrible leg cramps at night, and in the day gets finger cramps. What might cause this muscular cramping?
You know, in my world,
start?
one thing I think about, is there some electrolyte abnormality?
Sure.
Like, is your potassium off? Especially someone who's older tend to be on more medications, which can affect those. So that's one thing I think a lot about. Restless leg syndrome is another thing I would think about with that, less with the hands, obviously. And then some of those, rheumatological type issues definitely come to my differential too when I think of stuff like that.
Yeah. Do you have anything to add, Carl?
No, I would agree with the list that Alan stated. If one thing to think about is could there be any sort of, depending on if there's any kind of numbness, tingling sensation with it too, could there be what we call a neuropathy at play, and that kind of leads us into kind of a whole nother set of things to think about. But otherwise, I agree with Alan.
Yeah. Unfortunately, I feel like that's one of the complaints that I don't always find an answer to, the muscle cramps, but worth getting checked out because there are some causes. Let's see. Caller from Aurora, is fasting a good way to lose weight? I feel like I haven't heard as much about intermittent fasting as I maybe was a few years ago, but I guess how do you counsel patients when they have questions about, diets in general, but maybe intermittent fasting in specific?
Yeah. I think, with fasting and with a lot of diets, making sure that you're not doing this diet or doing this fast in a way where you could put yourself at risk. And by that I mean, I've seen some people, completely eliminate carbs, and then they're trying to exercise without any carbs, and that can be a dangerous situation. You don't have enough blood sugar to keep going, to stay upright, and you pass out. So you got to take some of these kind of dietary approaches with a balanced view, I guess. So in terms of the weight loss from intermittent fasting or from fasting, I don't know that there's great evidence to support it. I think really it comes down to just kind of the balance of trying to eat a healthy diet, watching your portions, and getting enough activity in the day to kind of balance out, what you're bringing in from a caloric intake perspective.
Yeah, great. Let's see. We have a caller from Sioux Falls. They had two kind of separate questions. First, what causes a TIA? So let's start there, Alan. What's a TIA? It's a challenging thing to explain, isn't it?
It can be, yeah. So you look up TIAs on the internet, you'll hear terms like mini strokes. But I try to break it down for patients by word. So it's a transient ischemic attack. So transient, the key there, and that's the key with a TIA, is that the symptoms come and go. Symptoms of a stroke, on the other hand, come and do not go. Mm-hmm. So a TIA is basically a stroke that with symptoms that resolve fairly quickly. The ischemic part is that the ischemic word is there's not enough oxygen getting to a part of the brain for a short amount of time. Mm-hmm. Now, in a TIA, that doesn't cause any long-lasting damage. Right. It can be a precursor, however, to strokes. What causes it? We know there are risk factors for strokes: high blood pressure, high cholesterol. So that comes down to what we were just talking about: eating a healthy diet, living a healthy lifestyle can definitely decrease your risks. Another big thing that I think we don't see as much of anymore, but smoking. That's a big risk factor for TIAs and strokes.
Mm-hmm. Yeah, I think the challenge sometimes it is really classic, unilateral weakness symptoms. Sometimes it's hard to be sure that what you had as a TIA, without that permanent evidence on any imaging or whatever. So sometimes the follow-up is a little challenging, but good. This person's second question was, what does divalproic do? Valproic acid.
Yeah, it can be used for a few different things. One's an anti-seizure med. Yep. Speaking of seizures. It can be used in certain psychiatric mental health conditions as well. It's not something we would be using in primary care setting, but potentially within a psychiatrist's realm.
Yeah.
We occasionally use it for migraine headaches in the
Sure.
too.
Yeah, great. Works in the brain. Let's see. Quick question, follow up from our earlier discussion, an email. I'm 89 years old. Do I need a measles booster?
I mean, and Kelly, you can weigh in too. My understanding is if you've ever had the measles vaccine, then you don't need to get the booster.
Yeah, and if you're over a certain age, the CDC still says no because we presume immunity because it was so widespread. So probably not. Great. As hearing loss becomes more prevalent with age, it's crucial to understand its impact, not just on quality of life, but also on cognitive decline. Dr. Todd Decker, a licensed audiologist and owner of Professional Hearing Services in Watertown, South Dakota, spoke with Prairie Doc about the importance of hearing health.
We should be looking at having our hearing assessed by the age of 45 to 65, somewhere in midlife. Earlier is better.
Decker says there have been studies that found an important link between hearing aids and cognitive decline.
There's a recent study just this last August. It's the Framingham heart study. It's actually a longitudinal study over 20 years. They looked at over 3,000 individuals, and they found that if you would treat hearing loss before the age of 70 with hearing aids, you reduced your risk of cognitive decline by 61%. If you waited after 70 for hearing aids, there was no reduction in risk factor for cognitive decline.
Hearing loss has a correlation with cognitive decline, but is not a cause.
Social isolation has a higher risk factor for cognitive decline anyway. So now if you add hearing challenge to that makes it worse. So as we have a hearing challenge, we're human beings. And so if it's really difficult for us to have a conversation with someone out in the public, we're not going to be able to add to the conversation because we can't hear well. If we get embarrassed in any way, we're not going to put ourselves out there. And so as we revert back into our quality of life at home, we're not stimulating ourselves.
When sound is not consistently reaching the brain's hearing centers, those areas can become deprived of stimulation.
Hearing help for individuals, the earlier that they get help, I've said it several times now, the better. Hearing help also, it can mean working with over-the-counter hearing aids. It can mean getting some type of hearing in your ears. I think the best practices, and obviously the more medical model, would be seeing an audiologist and working on your prescription.
Great information. I've had the experience twice recently where I went to look in one of my patients' ears and was about in their ear before I realized there was a hearing aid in there. So I always tell people, like, hearing aids are not the same as they were 10 or 15 years ago. They're getting discreet. We have a related question, a caller from Colton, South Dakota asking, is there anything to help ringing in the ears or tinnitus? Really common complaint.
Yeah.
What do you tell people, Carl?
Yeah, common complaint, and unfortunately kind of a tricky one. There can be certain medical causes for it, but to be honest, most of the time it just happens just because, and we don't know why. And so I do encourage patients to see an audiologist for tinnitus. There could be hearing loss associated with it that they may not necessarily be aware of. So I do encourage that. We'll obviously look in their ear, make sure there's nothing going on that could be pressing on that tympanic membrane and causing a disturbance like that. But yeah, I would say kind of the main thing is I generally always have a patient see an audiologist for that.
Yeah, good. Let's see, we had an email question about kidney disease. So this person was told they have stage 2 kidney disease with a number, we'll assume this is the GFR of 34, and recommended recheck in 6 months. What does this number mean? And how do we sort of stage kidney disease?
So that number, glomerular filtration rate. So that basically is, how efficient is your kidney? Is your kidney working close to what it should be? That number of 30 is low, or not as low as I've seen. Patients with dialysis can get essentially down to 0, where the kidney doesn't work at all. The stages of kidney, I have to defer to my primary care. I think it goes to 4 or 5. As far as, and then you get to what's called end-stage renal disease. Those patients end up on dialysis, which takes the place of their kidneys. I think with this scenario, is alluding to is that it's something you just want to keep an eye on. There are certain things that are hard on your kidneys, like taking a lot of ibuprofen as an example. So things to try to avoid: high blood pressure, get your blood pressure under better control to prevent progression. But in the short term, if you in my world, sometimes I see things that cause the creatinine or the kidney function to get worse acutely and then get better quickly. But more commonly, especially in chronic kidney disease, it's a progression over time. So understanding that it's something that you're just going to probably make some lifestyle modifications and then recheck with your doctor.
Yeah, good advice. Let's see, we had a caller from Box Elder. Do we foresee cures or more treatments for Alzheimer's dementia, or what is kind of coming with that? I would say we have a lot of shows most seasons on dementia, so definitely our website will have more expertise on that, but it's something that people worry about a lot.
Yeah, it is something people worry about a lot, and it's not an uncommon kind of question or complaint with older patients that come in, concerns about memory. Is this normal? Is this not normal? Is this Alzheimer's? And there are things we can do in the primary care realm or with, neurology or neuropsychology colleagues of ours to test, is this, a normal change in cognition or memory or not? Specifically with Alzheimer's, there's not a specific treatment or cure for it at this point. It's an area that's researched a lot, and studied a lot in clinical trials and whatnot. There are medications we can use to help try to slow the progression of it. But yeah, unfortunately, there's not a cure.
Yeah. I think there's reason for hope just with all the research, but we probably need some earlier detection tools to help us with that too. So good. Caller from Hot Springs, South Dakota. This is an 80-year-old woman who has been diagnosed with idiopathic pulmonary fibrosis. She asks, should I see a pulmonologist or should I just keep seeing my primary care provider and using the prescribed inhaler?
Yeah, I would probably encourage a pulmonology consult to really get a thorough evaluation and understanding of the condition. It could end up being something where after meeting with a pulmonologist, she can see her primary doc for kind of routine management of it. But I would encourage a pulmonary consult.
Yeah, absolutely agree. Great. Let's see. We have an email question, a 7-year-old child who, after having COVID, developed celiac disease. Now I feel like she's more susceptible to all the infections that go around. Is that possible to have a relationship between those things? I don't know. What would you say, Alan?
I think I would say it's possible. The issue with COVID is, thankfully, it's different than it used to be, but it's also relatively new. It's not been around as long as strep throat, as an example. So we're still trying to understand what are some of the long-term consequences of COVID infection. Does that necessarily mean if you've ever had COVID, you're suddenly just going to get all of this? No, I mean, some of that too is, at that age, I myself have been sick several times this year just because there's a lot of bugs going around this year that are virulent. So I wouldn't necessarily say that that's exactly why that's happening, but is it possible? Absolutely.
Yeah, hard to know for sure. Great question from Rapid City. How do you decide what injuries to use cold or heat on to the sports medicine specialist in the room? Please tell us.
A long-standing debate, and I'm not going to have a clear-cut answer for you. I don't know. So there are certain conditions where we would advise cold over heat. One example would be an acute sprain, like an ankle sprain, cold, icing that. What you're trying to do is help your body bring that swelling down, help your body address that inflammatory process. There are other conditions where we're probably going to advise heat, like a lumbar strain in the back, muscular strain, trying to get that tension out of the muscle. And then there's other issues where it's like heat, cold, whatever feels better to you, alternating them. those are often more chronic muscular issues, musculoskeletal issues, where kind of alternating them might be a good option. So there's not a clear-cut kind of one-size-fits-all answer.
Yeah, fair enough. All right, we had an email question. Alan, a man in his late 40s. Sometimes when I'm on my feet all day, my ankles are swollen at the end of the day. Usually goes away overnight when I rest. It's not painful. I am on blood pressure medication. What would you suspect might be the cause of this, or what things might we be worried about?
I would say persistent swelling. So for this gentleman that it's getting better, I would say I'm not very worried. My answer overall would be gravity. You're on your feet all day, all the fluid in our body, gravity's pulling it down. The same, if I'm a long day and I take my socks off, I'll have an indentation. That doesn't mean I have kidney disease or heart failure or anything like that. If you're starting to see a pattern, though, however, where my legs are getting swollen, they're not getting better when I'm getting off my feet, could be more of a sign of something like heart failure or kidney disease, and that'd be worth getting in with your doctor to get checked out.
Yeah. They say they're on blood pressure medication. There are some medications that actually can make this worse, right?
Yeah, common one, blood pressure medicine, amlodipine. That's not an uncommon adverse effect that we can see is some swelling in the legs. It's not something to be worried about, but it can be bothersome to a patient, enough so where we might switch their meds.
Yeah, we've encountered that situation plenty of times. All right, let's see. We've got a question from Sioux Falls. This is a fair question. I go to the doctor, and when I look at my chart, maybe the note from that day, I still see all the old issues in my chart. Can I get them off? Do you ever patients ask you about this?
Occasionally, unfortunately, some of that's just where we're at with electronic records and almost like too much information. So we do try to keep detailed records for us primary care providers when you go into the ER, so they can quickly look at a chart and get a sense for the medical history. If there's something on there that you don't think is relevant anymore, or maybe isn't entirely accurate, by all means, you have a right as a patient to bring that up to your provider, and that can be addressed.
Yeah. Sometimes those problem lists get out of control, and we can sometimes clean those up. But maybe it's relevant, and you just don't know why it's relevant to keep in your history, right? Let's see. We had an email question. Woman in her 50s having fatigue all the time. What could be causing this? Hopefully, you're not having to address this. This is the common primary care complaint, but.
Things I think about, if someone's having, weakness, is your pump working well? So is your heart behaving itself? Are you having signs of early, heart failure? Anemia is a big thing, especially in that age range. So if you're having, whether it's nutritional, like iron deficiency, if you're having vaginal bleeding from like a uterine fibroid, GI bleeding, that can be sometimes hard to even detect.
Sure.
Those are things that I think of when I think of fatigue. The other thing I would say too that that does come across the ER quite a bit, what's your mood? Like, do you feel like you? And I ask patients that a lot. And sometimes, if you are dealing with some depression, life is stressful. That can be another thing that can cause fatigue over time. So those are some of the things I think of from an ER. So.
Yeah. Anything else that you think of?
I agree with Alan. Unfortunately, it can be a long list of things that can cause fatigue. If you're coming in for the first time to have this evaluated, we're probably going to run some lab work, and use that as just kind of a quick look to see, hey, is there anything off with kind of basic lab work? And maybe use that as guide point if we need to do any other digging. But like Alan said too, there can be things outside of straight up medical problems, what's going on in your life, what's going on with your social situation, all that that can affect your energy level.
Yeah, the list is long. We have more questions, right? Okay, we got another question. 63-year-old in Rapid City. This person lives in a rehab facility. They're wondering if they should get a pelvic exam and a pap smear at age 63. So I guess you want to just remind us what are our cervical cancer screening guidelines there?
In general, up to age 65. is standard. So, technically still within that age range where that should be considered. If there's any kind of history there could be kind of varying kind of intervals at which that should be done, but in general up to age 65.
Yeah, great. I think we just have a couple minutes left. I feel like it might be a good opportunity to talk about sort of when the ER is the right place to go, because I think that's a common question that we're trying to answer on the phone, right, with patients. So I guess let's take the example of, we have a lot of illness going around, coughs and colds and stuff like that. What symptoms that might go along with that, Alan, would be something that would strike you as like the ER is the place you need to be evaluated?
Not being able to breathe would be probably the first one. We've all had colds, coughs, they're annoying. That's different though than I can't catch my breath, or I'm breathing too quickly, or I'm feeling lightheaded and dizzy. Anytime those symptoms are getting to the point where they're affecting your ability to function, that'd be what I would say to come to the emergency department. Now, I'll tell you too, I get man flu, so my wife will tell me sometimes that, my ability to function, be real with yourself. At the end of the day, however, I always, and I tell our students when they're working with us in the ER, if people are worried to the point that like you think that something bad's going on, that's why I exist. Even if it's something that is quote unquote doesn't need to be in the ER, if you're worried enough about it, come in and it's easier for me to say you're okay than to something bad happen at home. So if you're ever in doubt, come in. But I'd say in general, those big symptoms are the things I watch for.
That would be the big thing, yeah. And I think the great ER docs that I know come with that attitude, right? It's like I'd rather see you and check you out okay than you not go to the right place, because there's things that we just can't do in the clinic as far as quick assessment and stabilizing people that are really sick. So great. Well, we appreciate all of your expertise. Our winner tonight is Jack. A book will be sent to you shortly, Jack. We'll be back after this.
My name is Dr. Tad Jacobs, and I serve on the Healing Words Foundation, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Don't miss out on the latest insights into health and wellness. Be sure to pick up a copy of your local newspaper or explore the Prairie Doc Perspective online, a weekly column dedicated to providing valuable information on health and medical topics. Access all previously published columns and stay informed by visiting www.prairiedoc.org.
As we finish up tonight's discussion, I want to thank Dr. Sazama and Dr. Rasmussen for sharing their expertise with our viewers. And thank you to all our viewers for tuning in tonight. We appreciate your continued viewership and support each week as we provide science-based health education to everyone. Don't forget to follow us on Facebook, Instagram, YouTube, and TikTok for more information and updates. If you missed sending in a question tonight or it didn't align, send your questions to ask@prairiedoc.org to be answered on our weekly radio program, Prairie Doc Radio, Sundays at 6 a.m. and 1 p.m. on SDPB Radio. And be sure to download and subscribe to the podcast version of this show and Prairie Doc Radio, wherever podcasts can be found. Thank you for joining us on another On Call with the Prairie Doc. Until next time, as our founder, Dr. Holm, would say, stay healthy out there, people.
Allergies are hyperactive immune responses to substances that the body mistakenly identifies as harmful. They can range from discomfort to life-threatening. Allergy awareness, understanding triggers and treatments. Next time on Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,